Well, good afternoon to everyone. It's a pleasure being able to join you all virtually. I'm Gus Alva. I'm currently the Medical Director for ATP Clinical Research in Costa Mesa, California, and the Director for the Senior Brain Health Program at Hoag Hospital here in Newport Beach, as well as being part of the faculty at the University of California, Riverside within the Department of Psychiatry and Neuroscience. I happen to be a Distinguished Fellow at the American Psychiatric Association, and it gives me great pleasure to be able to share the content of, again, the topic that we're going to be covering, which is early treatment of Alzheimer's disease, including mild cognitive impairment. So we've got a lot of material to cover before us. I'm thankful that you're here with us because that basically means that you're highly interested in reviewing the current definitions of Alzheimer's disease. So what we're going to do is we're going to discuss the current approaches for screening and diagnosing not just Alzheimer's disease, but mild cognitive impairment due to Alzheimer's disease and mild Alzheimer's disease dementia, because it turns out that the sooner we can detect this particular problem, the better we can actually address the myriad of issues that come about with it. We're going to highlight the rationale for detecting patients early in the Alzheimer's disease continuum, and we'll review the potential implications of what an earlier diagnosis of Alzheimer's disease might mean for patients as well as the healthcare system, specifically earmarked towards treatment. What I want you to take from this particular slide is that although the most common form of dementia that we diagnose at the present time is Alzheimer's disease, you'll note that there is a lot of interlap. As we take a look at the Venn diagram where we've got multiple conditions cited here, you'll note that Alzheimer's disease accounts for about 60 to 80% of dementia. However, 1 out of 2 dementia cases have mixed pathologies, which oftentimes overlap with Alzheimer's disease, and this is through autopsy confirmation. So we're pretty much sure that, again, the pathology that we're seeing in the brain is congruent with what we're seeing. Let's do an overview of Alzheimer's disease and see why it is so important for us to be keenly aware of this condition. This is an illness that has a substantial impact on not just the individual that suffers from it, but also family members or caregivers. This is the 6th most burdensome disease in the United States, and as we take a look at what that entails, that's basically looking at the overall disability that comes about from having the condition. 1 in 2 nursing home residents has Alzheimer's disease or another form of dementia, and we note that 1 in 3 older adults will die from Alzheimer's disease or another dementia. 83% of caregivers are generally going to be family members or friends, and we note that there's about a $244 billion expenditure in unpaid care by loved ones, meaning this is a labor of love. Oftentimes, 30 to 40% of family caregivers will report suffering from depression or anxiety themselves, so we basically see that there's a heavy toll or a heavy price to be paid as a caregiver. Within the clinical ambit, we basically know that there's a shortage of specialists. There's 1 geriatrician for every 1,924 older adults, and about a 19% shortage of neurologists that is estimated by the year 2025. Within the primary care setting, this is oftentimes where individuals are first diagnosed. We note 85% of dementia diagnoses are made by non-dementia experts. So that basically limits things greatly. As we stated, expenditures are high. There's an estimated $305 billion that are spent in caring for Alzheimer's disease and other dementias. And by the way, that is information that is about 2 years old. 67% of costs are covered by Medicare and Medicaid, so we note the federal government is going to be the heavier payer out of this, and less than 20% of Medicare payments are for providers and drug treatments, meaning that there's a loss of function not just by the individual, but certainly also the people that care for them. So why are we seeing so many people with Alzheimer's disease? Well, as our population within our community ages, we see that Alzheimer's disease continues to grow exponentially. This is a neurodegenerative condition that is associated with advancing age, meaning that in the past, people might have lived to their mid-40s At the present time, people live towards their mid-70s on an average, and we're basically seeing that the older aging group is growing at an even greater rate than other groups, which basically means that as we take a look at a condition that favors individuals who happen to be older, well, as medical professionals, we've managed to address medical comorbidity better, which means that the typical diabetes, high blood pressure, cardiac disease, other conditions that in the past would have robbed individuals of life are now able to be countered effectively. That then means, however, that individuals might be more prone to conditions like Alzheimer's disease. Let's take a look at some basics. So here's a microscope and here is a brain. So morphologically, this is what a brain looks like. Imagine a mass that's about 3 pounds and basically the most important part of our body. When you take a look at the pathology that abounds with Alzheimer's disease, we typically talk about beta amyloid plaque deposition in the middle there on the bottom, and hyperphosphorylated tau to the right, in which a disruption of the cytoarchitecture of the neuron becomes compromised. We basically note that these two pathognomonic features are the associated issues that we recognize with Alzheimer's disease. So on a slide like this, you'll note to the left a very healthy brain, nice and plumpy, where you don't see much space between those gyrations on the outer cortex, as opposed to the severe Alzheimer's case that's shrunken dramatically. From a histopathological perspective, you'll see the plaques, or that gunky form of beta amyloid, and the neurofibrillary tangles, which, like I said, are generally found in individuals with Alzheimer's disease. So we basically note that amyloid plaques and neurofibrillary tangles are implicated in widespread neuronal degeneration. This is important because not only is this a pathognomonic feature, meaning something that we'll always find in Alzheimer's disease, but we're now utilizing it, and we've spun the story around by looking at the predictive validity of maybe seeing this and maybe diagnosing individuals earlier. If you see this woman, her name was August D. She was the very first patient that was described with Alzheimer's disease, and the gentleman that did so in the literature was this Bavarian psychiatrist. His name was Alois Alzheimer, and thus we get the name Alzheimer's disease. So the interesting thing is that the diagnosis of Alzheimer's has historically been one of exclusion, meaning that doctors, if suspecting the possibility of Alzheimer's disease, would do a cognitive screen. If all of a sudden there was some question as to whether the individual might have a problem, a full workup would be done where we would want to rule out all of the usual things. So a medical history review, medication review, because keep in mind that medication combinations will sometimes evoke a confusional state in people. A physical exam with a good neurological exam, screening for depression, which is oftentimes known as pseudo-dementia, performing lab tests, because there's certain things that might be able to be reversed that if caught in a simple blood test would be good, and certainly ordering structural neuroimaging. So we basically see the possible causes of cognitive symptoms could include things as mundane as medication interactions that could be faulty, chronic disease, depression, certainly the loss of being able to hear or see things, because if you can't encode information well, then that might be difficult to recall. Endocrinopathies like thyroid dysfunction, certain vitamin deficiencies like B12, anemia, infections, generally urinary tract infections, lower respiratory infections can cause a delirious state, which could be fixed. Vascular abnormalities, metabolic abnormalities, even sexually transmitted diseases like syphilis or HIV infection can cause problems. Exposure to heavy metals, Lyme disease, Wilson's disease, Jakob-Creutzfeldt disease, just to name a few. But as you'll note, we have a laundry list of typical things that we would look for. We basically also understand, based on studies that were done by Brack and Brack, and by the way, these date back a significant amount of time, that Alzheimer's disease pathology generally starts out in primitive portions of the brain. So again, limbic regions usually involved, nucleus basalis of Maynard, and then subsequently there's a migration upward. So the typical problem is that the temporoparietal region of the brain, meaning the upper and lateral parts of the brain, are going to start getting affected, and then subsequently that'll move over to the frontal lobe. So as you'll note from this slide, there are different stages that we follow, and with it, changes with amyloid or the neurofibrillary changes that we were speaking about. This can be used in our favor, and I'll share with you how. So there's some interesting hypotheses. Among them is that, if you've got too much buildup of a gunky stuff that shouldn't be in the brain, like amyloid, well, this is something that's been central to the overall neuropathology of Alzheimer's disease. The amyloid precursor protein is coded for by a gene, and basically we know that this resides in chromosome 21. That's why, by the way, all individuals that suffer from Down syndrome, if living long enough, will develop symptomatology that's very much like Alzheimer's disease. We know that there are certain types of SNPs that occur with different enzymes, beta secretase, gamma secretase, that if all of a sudden they cut or they cleave this particular protein, might build different types of peptides and subsequently oligomers, which are neurotoxic in the brain, and that creates problems. That is, however, not the full story. We basically think that there are other hypotheses along the lines of the neuropathology. And we talked about tau. Tau is also believed to be a primary causative pathology because as hyperphosphorylation occurs in neurons, which are the building blocks of the cells that compose our brain, there's going to be an aggregation of different things, and there's going to be a cytoskeleton disruption within the neurons. Unfortunately, imagine a room where if you took out the support columns, well, that room would cave in. And so the same thing happens here where you see neuronal cell death, and we think that mitochondrial dysfunction is a primary causative pathology. So we basically see that there's going to be specific problems that set in with inflammation, vasculature, and different types of neurotransmitters or chemicals in the brain that oftentimes are very important for forming and retrieving memory. So coming back, the core issue here is that the symptoms associated with Alzheimer's disease are believed to be the result of underlying neuropathological changes and brain atrophy, meaning shrinkage, right? So we basically see that as individuals are affected by this illness, there's going to be a marked neurodegeneration. And we think that those plaques and tangles lead to neuronal loss, and that neuronal loss will lead towards symptoms. And the main symptoms are typically going to be short-term memory deficits, and we think that that short-term memory deficit is attributable to that neuronal loss. So let's take a look at where we're at the present time, because we've, by the way, made strong strides in trying to figure out how to tackle this nasty illness. We think that Alzheimer's disease exists within a continuum, and this is represented by multiple progressive stages. So what you see before you here is the National Institute of Aging and Alzheimer's Association Alzheimer's Disease Continuum, in which stages 1 and 2 are preclinical, meaning the individual doesn't really have any symptoms associated with memory decline. Stage 3 is the very first stage in which individuals have a subjective sense that their memory's not quite as keen as it was before, but they can still do their job. They can still do their domestic chores. They can still engage to a point that most people don't recognize that there is actually a problem that's brewing. Mild Alzheimer's disease is stage 4, where individuals now have some loss in their ability to function. But by the way, that mild stage is usually associated with mild loss. So still, most people don't get detected. And you'll note that moderate and severe dementia are associated with stages 5 and 6. And the sad thing is that at the present time, most people are first diagnosed when they're already in stages 5 or 6. So what you'll note is that in the stage in which the individual is affected preclinically or through mild cognitive impairment, we may actually have bought ourselves a sufficient amount of time, because take a look at this. if you take a look at memory, if you take a look at neuropsychiatric symptoms, and if you take a look at functional ability, you'll note that in the preclinical stage, individuals are pretty much unencumbered. In the mild cognitive impairment stage, there may be some subtle symptoms, but the individual is pretty much able to lead life the way that they've been doing so. In the early stage of the mild Alzheimer's case, so meaning stage 4, that's where we start seeing some neurobehavioral disturbances that might become a bit more overt, and functional impact on daily life is now noted. And then subsequently, in the moderate and severe Alzheimer's disease stages, that's where caregivers really have to step in and help out not only with instrumental but also basic activities of daily living. But as we're looking at an illness that exists within a continuum, there's also a continuum of pathological changes. Follow this with me, please. If you take a look all the way over to the left, you'll take a look at the fact that in the preclinical stage, people don't have any memory complaints, right? But they're already showing A-beta positivity. And this is something that can be picked up through a PET scan or a cerebrospinal fluid assay. You'll note that there are going to be subsequent tau-mediated neuronal injury and dysfunction. That is also something that can be picked up with a specific PET scan that takes a look at tauopathy or cerebrospinal fluid assays. Now, the subsequent scenario associated with memory decline now starts in when the individual starts creeping into that mild cognitive impairment stage. But you'll note that, generally there's going to be a preservation of function until that individual now steps over into the full dementia state, and that's where we see clinical function decline. But what we're tracking then with this is that amyloid changes might precede the onset of dementia by about 20 to 30 years. Think on that. If you had a 20 to 30 year lead-in and could prepare for what to do, that would be a lot better along the lines of setting up proactive rather than reactive responses to developing a particular problem. Now, dependent on the amount of information that somebody has accrued, meaning their education or their work performance, they develop what's called cognitive reserve. And this might compensate for the neurological changes that enable individuals to appear relatively asymptomatic, but we know that there's underlying pathology that's already brewing. Now, keep in mind that preventing Alzheimer's disease might lead to successful cognitive aging. And we know that aging need not be accompanied by a decline in cognitive functioning, because, by the way, 1 out of 3 individuals will maintain pretty well. And we basically see that about half of individuals are going to have minor decline, but then you subsequently see that there are individuals that are major decliners. So the maintainers generally have greater educational and literacy levels, which might translate into that concept of cognitive reserve that I was speaking about. And by the way, for those of you that might be thinking, are there certain factors that might be preventable or modifiable to not necessarily develop Alzheimer's disease? The answer is yes. Not smoking. Having regular activity, both physical and mental, is a good idea. Being socially involved, and watching one's weight, meaning what you eat is what you get out of things. So being careful with things that we basically put into our bodies is very, very important. So when we take a look at pathology to the clinical stage and diagnosing Alzheimer's disease, we basically see that as there are problems that are brewing in the brain, there's going to be additional damage to brain regions, and we know that Alzheimer's disease can be diagnosed before a significant decline in cognition and function. And that's what I'm going to be earmarking much of my conversation on with you. Because once the horse has left the barn, there's going to be a decline in cognition, a decline in function, and an increase in behavioral issues, which subsequently is oftentimes the things that will herald a diagnosis in the majority of individuals. But for that astute person that thinks, when might we be able to first detect this? There are several things that we need to be aware of. Magnetic resonance imaging has been used qualitatively and quantitatively in Alzheimer's disease, and we basically generally utilize this to take a look at patterns and regions of brain loss. And this is certainly something that can help us differentiate a healthy control from somebody with Alzheimer's disease. But guess what? Our science has grown remarkably. Now we have functional neuroimaging, and examples of that would be positron emission tomography. We have tracers or radioligands that can be injected intravenously that are taken up in the brain that show where there is a reduction in brain metabolism that might be associated with synaptic loss and function. So here to the left, you'll see a controlled patient where we're looking at a rainbow-hued color scheme where the hotter colors indicate more function, cooler colors less. So you'll note to the right the individual with Alzheimer's disease has arrows that are pointing to the temporoparietal region bilaterally. And in this particular example, we see that there's a decrease in function on both sides of the brain here that would be very much indicative of probable Alzheimer's disease. Doesn't stop there. Now we've actually gotten to the point where we can image that gunky stuff that shouldn't be in the brain, meaning the amyloid, and there are radio tracers that just latch on to the amyloid, and now we can actually see the difference between elderly patients that are controlled, meaning no cognitive impairment at the bottom, versus the individuals with Alzheimer's disease on the top, where regardless of which cut is being done with the specific imaging technique, you basically see that the brain's lighting up more because there's more amyloid there. And so the important thing is that now we've actually turned this story on its head. So yes, there's pathology, but now if we can actually track it earlier, that gives us then a potential role of utilizing biomarkers in making an earlier diagnosis. Let's talk about that. Whether it be the National Institute of Aging and Alzheimer's Association, the International Working Group, or the Diagnostic Statistics Manual 5th edition, we basically note that biomarkers have a great degree of utility so long as clinicians are aware of them and so long as the community is also aware of them. So we basically note that if somebody were to, for example, have suspicion that they might be suffering from mild cognitive impairment or very early Alzheimer's disease, well, by looking at cerebrospinal fluid, and give you an example here at Hoag, we have a phenomenal interventional radiology department that can actually do fluoroscopy-guided lumbar punctures and be able to very safely extract cerebrospinal fluid. By taking a look at an assay of cerebrospinal fluid, you basically see that if there's a mismatch of beta amyloid in the cerebrospinal fluid versus the brain, and if you see that there's an increase in the amount of total or hyperphosphorylated tau, then a diagnosis can be more readily made that's accurate in nature even before symptomatology sets in. So the important thing is that when we take a look at different studies, whether the individual has no prodromal Alzheimer's disease or prodromal Alzheimer's disease or low likelihood or a high likelihood of developing Alzheimer's disease, you'll know that generally when biomarkers are tied in or tethered to cognitive assessing, we basically have a much higher diagnostic accuracy rate over the course of, say, a 3-year progression rate in which individuals develop full-blown Alzheimer's disease. That's now brought us to the present, which is the fact that biomarkers appear to have a terrific impact on early detection and diagnosis of Alzheimer's disease. And so now, rather than looking at a diagnosis of exclusion, we're looking at a diagnosis of inclusion where we're utilizing biomarker assessments. Because, by the way, it's as simple as doing a lumbar puncture and checking for the amount of cerebrospinal fluid of amyloid beta. And also taking a look at tau, hyperphosphorylated total tau, and then specifically other fancy ways of doing this would be the use of that PET scanning, positron emission tomography, utilizing either fluorobetapir or other types of radioligands that specifically latch on to beta amyloid plaque deposition. Now, keep in mind, this is not the full story, and obviously there's been a ton of work being done in the field for quite a few years. So bear in mind that at the present time, there are only 4 accepted treatments for Alzheimer's disease, and there's only one treatment that's been FDA approved for mild cognitive impairment or very early Alzheimer's disease. And it took about 18 years for the last medication to get FDA approved. However, the utility of that particular medication, a monoclonal antibody, is highly limited because the Centers for Medicare Services are reticent to actually pay for the medication unless a patient's involved in a clinical trial. More on that in a second. So we made mention that the most widely studied biomarkers in Alzheimer's disease right now are that beta amyloid plaque and that hyperphosphorylated tau. And the two ways in which we can do that right now is through cerebrospinal fluid and through neuroimaging that's functional in nature, specifically positron emission tomography. Hopefully in the very near future, there will be a blood test that would actually be a lot cheaper and more user-friendly to be able to actually make that diagnosis. That, however, is not quite ready for prime time yet. It's not because of a lack of trying. Trust me, we've been doing a lot of investigational research work in this space, but again, that particular assay is still not quite ready for prime time. So why do we want to do an early detection of Alzheimer's disease? Well, this could lead to early diagnosis and lifestyle-based interventions. For example, some of the benefits of pursuing an earlier detection would be identifying whether there are reversible or treatable non-Alzheimer's disease causes of cognitive impairment that could be assessed. Patient families gain better understanding of cognitive symptoms. That's never a bad thing. And discussions about the treatment care planning can certainly ensue with the individual fully participating that might subsequently not be able to do so once the illness sets in fully. Non-drug lifestyle-based interventions can certainly be employed, and legal and financial planning can take place, because one of the saddest things is when individuals haven't necessarily prepared for this appropriately and then they subsequently get savaged through the legal system. Patients and families can access needed support services, and the sooner that's done, the better. So as we take a look at what the overall assessment should look like right now, we basically know that regular cognitive screening is essential for early diagnosis. So I'll give you an example. If you're over the age of 65, you should be having a cognitive exam on a yearly basis. And here at Hoag, we have the availability through the folks from MBIC to utilize something like the mild cognitive impairment screen, which is a very easy screener. We call it a digital biomarker to be able to detect mild cognitive impairment a lot sooner than would otherwise be the case. And here's a few examples of different screening tools that might be used. You'll note the mild cognitive impairment test or screen will take about 10 minutes, and it is highly sensitive for mild cognitive impairment versus normal aging. There are other tests that many clinicians will use, including the mini mental status exam, mini cog. Again, there are different types of assessments that basically might take up a little bit more time, but not necessarily have the same degree of validity associated with what the mild cognitive impairment screen offers. In the conduct of doing clinical trials, we do other things like, the CEDAR, some of the bogs. So when we take a look at, cognitive area of dementing rating scales, we basically also incorporate things like the Alzheimer's disease cooperative study groups, cognitive scales, the repeated battery for the assessment of neurological symptoms. But you'll note that all these assessments take a long time, and there are different ways of being able to test people out. But if you can incorporate simplicity to the picture, that actually helps out greatly. By the way, we basically know that early detection along the Alzheimer's disease continuum begins with mild cognitive impairment due to Alzheimer's disease. And we basically know that the overall prevalence estimates of amyloid positivity according to cognitive status by age will certainly increase along the lines of the individuals that will subsequently end up with serious problems as they get a little bit older. We talked about current therapies that exist for Alzheimer's disease. To the left, you'll see the cholinergic synapses or the cholinergic hypothesis, and to the right, the glutamatergic hypothesis, where we've got an NMDA receptor antagonist. So to the left, you've got three medicines that block the breakdown of acetylcholine. So there's donepezil, rivastigmine, and galantamine, and many clinicians will sometimes utilize these medicines, sometimes they will not, because here's the problem. These medicines do not arrest the overall progressive nature of this illness. We've got an NMDA receptor antagonist called memantine or Namenda, which basically doesn't allow too much calcium to flux into the postsynaptic neuron and fry it out. So in very simple language, on the one hand, 3 medicines that block the breakdown of acetylcholine, but here's the problem. As the different cells that have died that previously produced that particular neurotransmitter continue to do so, you basically get a limited benefit associated with cholinesterase inhibitors. And regarding an NMDA receptor antagonist, these are medicines that are earmarked a little bit more towards the later staging of the illness. Good news, however, is that you'll note based on this graph that I did make mention of donepezil, galantamine, rivastigmine, and memantine. And by the way, there's a combination donepezil-memantine medicine called Namzaric, which makes it a bit simpler for individuals to take a combination of medicines. A colleague of mine by the name of Ali Audrey, who now resides in Arizona, but previously was working out of the Mass General, Ali Audrey, contributed nicely to the field by having a study where a combination of donepezil with memantine actually fared better than either or alone or no treatment. But if you'll see, the new approved treatment that's available is Aduhelm or aducanumab. Aducanumab is a monoclonal antibody that's directed to the N-terminus of the amyloid beta peptide. What does that mean? That means that individuals that, might benefit from this particular medicine would have a mild cognitive impairment or very early Alzheimer's stage, and they could be taking a cholinesterase inhibitor. Keep in mind, memantine is generally not approved for individuals in the mild stage of Alzheimer's disease, although when we call it mild, we're really talking about the fact that this is an illness that's already progressed significantly. Now, the way to be able to get this particular medicine is through a clinical research study right now, because although it is FDA approved as of this past year, Medicare basically said that they would not pay for this medication unless somebody were involved in a clinical trial. Now, the way to be able to get entry into this is through confirmation of Alzheimer's disease through a lumbar puncture and taking a look at cerebrospinal fluid, or a PET scan looking at beta amyloid plaque positivity and what's called a centuloid burden in the brain. And by the way, it's also important to do genotyping assays in individuals, because the people that happen to be homozygous carriers of the ApoE4 allele, meaning both mom and dad gave them an E4 allele, have a higher risk of developing what's called a amyloid-related imaging abnormality, which could be hemorrhagic or edematous. And although in most cases that would be asymptomatic, it could potentially be something quite serious, and thus there's a need for tracking the individual with serious MRIs as the medication is being progressively increased in dose. So the good news is that Hoag has the availability and the resources needed for the appropriate use of aducanumab if somebody were to want to pay for this out of pocket. There's clinicians that are skilled in detection and recognition of early Alzheimer's disease, such as myself, amyloid PET access or access to individuals with lumbar puncture expertise. I made mention of our interventional radiology department, experts in amyloid PET scanning interpretation or CLIA certified laboratories available for CSF measurements, which obviously we do, and infusion resources as well as MRI access to be able to rule out the potential for ARIAs on those MRIs, and what to do if all of a sudden one of those popped out. And by the way, the need for genetic counseling for patients, because an ApoE assessment would need to be done. Now, for the most part, there's different types of criteria. Obviously, only individuals within specific diagnostic criteria would be able to get this medicine, and that would be mild cognitive impairment or early Alzheimer's disease. And we basically know there's a plethora of different things, including if somebody would have been on a blood thinner, obviously this would not be the best choice for them. But there's a whole slew of different things that, clinical trial enrollment will require 4 criteria for individuals that don't necessarily want to pay for this out of pocket would have to do so. And by the way, the reason I mention this is that it would be relatively costly to be able to track individuals by doing this because you have to be doing serial MRIs. And the reason behind this is that 41% of the individuals that were treated with aducanumab experienced some type of amyloid-related imaging abnormality. And the overall scenario here is nicely exemplified that as you go up on the dose, you basically follow up with an MRI scan. And like I said, the neat thing is that anytime anything new occurs within our field, Hoag is certainly going to be deeply involved with laying out a program so that our community recipients could benefit from potential use, and there's all sorts of different things for that. Let me now steer towards another area that's very important. Hoag has linked in with what's called the Orange County Vital Brain Program, and this is a population-based prevention program which promotes cognitive health through public and physician education, much like what we're doing right now, in-person cognitive assessment services, which have been limited because of COVID, but also online contents and self-assessments, as well as the coordination and triage of healthcare resources and the availability for participation in clinical trials and clinical studies. Now, why did I make mention of that? Well, Hoag has clinical trials and studies that are available for individuals. I happen to be the principal investigator of the INTERCEPT study, which, for example, investigates the efficacy and safety of an investigational treatment that is made by a company called Acumen in mild cognitive impairment or early stage Alzheimer's disease. Very much like Aduhelm, but potentially safer along the lines of not evoking the same degree of amyloid-related imaging abnormalities. And we have the AHEAD studies, A3 and 4 and 5, which are basically earmarked to take a look at individuals who are preclinical, no symptoms yet, right? And so that's good news because, by doing this work, we're basically looking at a way of being able to help out individuals a lot sooner than what would otherwise be the case. So the important and exciting news that I wanted to share with you right now is that there is now a way of typifying patients based on digital, like the mild cognitive impairment screen tests, and biological markers like lumbar punctures and PET scanning imaging results. Earlier intervention might spell out additional benefit for cognitively compromised patients, but even if that individual didn't get treated or recognized early on, there are other things that could be done for them. To date, all the medicines that are currently available have been palliative and benefit individuals in a scant manner. But we now have the potential for maybe reversing some of the progressive nature associated with Alzheimer's disease. And although Aduhelm was a medicine that showed that you could reduce the plaque burden in the brain, it's still left to see whether there's going to be functional improvement in those individuals that have less beta amyloid. So treating mild cognitive impairment at that level may evoke disease-modifying effects on patients. The controversy with Aduhelm or aducanumab needs to be discussed with patients, but allows a possibility for clinical research involvement, which Hoag is more than able to accomplish. With that said, I thank you all very much for your time. And what we will do now is take some time for Q&A. So thank you very much for your kind attention. And we're giving some time for questions. And we're looking great in time, guys. The staff here knew that I was typically long-winded, so they basically said, hey, keep it down a little bit, would you? And I love the fact that Hoag is able to provide educational pieces like this to our community, so as to better serve the people that live here locally. I heard we had a couple of hundred people out in the audience there, so if anybody has a question, by all means, this is your moment to shine.
Currently seeing a neurologist. She has run the memory and Alzheimer's office test. I'm borderline. Also, she has prescribed Memantine, which is what I've been taking.
So I guess there was a question about the utilization of Memantine in a patient diagnosed with Alzheimer's disease. As I made mention, Memantine is Namenda, and it can be given by itself or in combination. It comes in two different forms, either an immediate release or an extended release form. And it also comes combined with donepezil. The use of Memantine is generally relegated for individuals that happen to be more in the moderate to severe staging associated with Alzheimer's disease. And the question here is, are there clinical trials in the area? Yes, there's a plethora of studies that are available in the area. And in fact, one thing that you can do is take a look at a website called clinicaltrials.gov. That will list all of the different studies that are being done in the U.S. that have been vetted by the FDA, that are obviously being done at centers that are reputable and prestigious. Here at Hoag, we have several different studies that are currently available. Like I said, predominantly for individuals with mild cognitive impairment or very early Alzheimer's disease. I'm excited over the fact that we're going to be doing a stem cell study with individuals with Alzheimer's disease, and our neurosurgery brethren, particularly in the case of Dr. Chris Duma, there's going to be some nice involvement along the lines of being able to deposit stem cells directly into the lateral ventricles through a Mamiya reservoir. So that's one of the really exciting things that's coming out right now. But there are also studies that are being done right now. There's a specific question about lecanemab and whether we are doing work with that. Yes, we are doing work with several different monoclonal antibodies. So it's not just aducanumab, there's lecanemab, and there are other monoclonal antibodies. I made mention of the Acumen study that we're doing. That takes a look at a slightly different approach that might have less implication of beta amyloid plaque burden. I made mention I'm the medical director of ATP Clinical Research, and obviously we do studies in that particular site also. If you looked up atpcr.com, you'd be able to take a look at some of the different trials that we're doing. But the Alzheimer's Association, both the Orange County chapter or the Alzheimer's Association itself, there are 2 chapters here locally in Orange County, would be also phenomenal resources to be able to take a look at different trials that are done. Local universities also have them, so it's just a matter for individuals to be on the lookout for things. Suffice it to say, though, Hoag has some pretty exciting work that's currently available, and it's as easy as asking one's provider to get a referral over, and specifically then have the opportunity of being able to partake. Thank you very much, and again, it's been a pleasure and a joy being here with you all.